Hello everyone. So let us continue with the next session of vasculitis. So in the last session, I'm just revising. We have discussed Takayasu arthritis, giant cell arthritis. Please remember what are the important vessels that are involved in both. Number 2, what are the clinical features. Number 3, what are the typical morphology. With that, we are going to discuss about the medium vessel and next is small vessel vasculitis. In medium vessel vasculitis, we have polyarthritis nodosa, Kawasaki disease. Polyarthritis nodosa, I have already told you what is the type pathogenesis, type 3 hypersensitivity reaction, that is immune complex mediated. In Kawasaki disease, I have already told you it is like a type 2 hypersensitivity reaction, that is anti-endothelial cell antibodies. Okay, fine. These two are the points that you should be clear. Fine. Now I'm going to give you a case scenario of polyarthritis nodosa. An young male presents to an emergency room with a severe abdominal pain. Small bowel infarction has been seen. Whenever you heard the word infarction, you have to always think of polyarthritis nodosa. What is your probable diagnosis? Sometimes they may give on microscopy, they may show fibrinoid necrosis, but usually it won't be given. That means a history of infarction will be given. So what will be a most probable diagnosis? What infection is most commonly associated with polyarthritis nodosa? Answer is hepatitis B surface antigen. Hepatitis B surface antigen. Remember, polyarthritis nodosa has no association with ANCA. No association with the ANCA. You know what is ANCA? Anti-neutrophil cytoplasmic antibodies. We have CNCA, PNCA, antiproteinase 3 and myeloperoxidase. Fine. Okay. So remember, hepatitis B surface antigen. That is important. It affects medium-sized muscular artery. Very, very important. Very, very important. It is going to affect the renal and visceral vessel. It is spare the pulmonary circulation. That is why there will be a history of bowel infarction. There will be a history of bowel infarction. Fine? Yes. Coming to the morphology, already you are well versed with the morphology of polyarthritis nodosa. There will be segmental transmural necrotizing inflammation. Fine? There will be aneurysm or thrombosis. Fine? Then kidney, heart, liver and gastrointestinal tract are involved. Out of that, the most commonly involved is kidney. Okay? Kidney. Then comes heart. Okay? Then comes liver. Finally, GIT. This is the order, please remember. Fine, okay. And there will be ulceration, infarcts, ischemic atrophy, hemorrhage, all those things. Fine. So then whenever there is an acute phase of polyarthritis nodosa, there will be transmural inflammation. What do you mean by transmural? That means involve all the blood vessel layer. That is the meaning of transmural inflammation. There will be mixed infiltrate of neutrophils, eosinophils and mononuclear cells. This is usually accompanied with fibrinoid necrosis and luminal thrombosis. Very, very important. So this is the morphology. So PAN, common in young adults. Okay. And next is very, very important point. See, the typical presentation will be rapidly accelerating hypertension due to renal artery involvement. Then there will be abdominal pain, bloody stools caused by vascular GI lesions. Okay, peripheral neuritis. Remember, the most important cause of mortality is renal artery involvement. So the PAN is typically fatal when untreated. So these are the important points you have to remember. In case of polyarthritis nodosa. So this is the typical picture. Okay, this picture already we have seen in fibrinoid necrosis, which is a type of necrosis, necrotic pattern that we have studied in cell injury. Am I right? Yes. And what you are seeing here is the fibrinoid necrosis. Okay, and you can see what is that neutrophilic and mononuclear infiltrate. Fine. Then coming into Kawasaki disease. Okay, it is an acute febrile illness of infancy. Very, very important. Infancy. Less than 4 years of age. Okay, yes. Mainly it involves coronary arteries. It causes thrombosis. Even it can cause myocardial infarction. The most common etiology is a predisposing viral infection. Okay, the patient will have a history of viral infection. Patient in the sense, a baby, child. Fine. I have already told you what is the pathogenesis, anti-endothelial cell antibody. What is the morphology? It almost resembles like PAN. there will be transmural inflammatory infiltrate, but the fibrinoid necrosis is less prominent compared to polyarthritis nodosa. Fine? Yes. I'm going to give you a clinical case scenario. Fine? See, it presents with conjunctival and oral erythema, blistering, edema of hands, and there will be desquamative rashes and cervical lymph node enlargement. So, I'm going to give you the history here. A 3-year-old child brought to hospital with complaints of fever, rash, swelling of hands and feet, erythema, desquamative lesions of palms and soles, cervical lymphadenopathy. What is your probable diagnosis? Kawasaki disease. Since there is involvement of skin, lymph nodes, that is why Kawasaki disease is also called as mucocutaneous lymph node syndrome. Mucocutaneous lymph node syndrome, you should know this term. Mucocutaneous lymph node syndrome. Okay, it has been asked in JIPMA 2 years back. Mucocutaneous lymph node syndrome, it is the other name of Kawasaki disease. Fine? Yes. And remember, one of the most important treatment for Kawasaki disease is IV immunoglobulin. IV immunoglobulin is the treatment option. Fine? IV immunoglobulin is the treatment option. So I hope you are clear with this. Yes? Okay. Then a word about microscopic polyangiitis. So with this we have finished about medium size vessel vasculitis. Next we have small cell vessel vasculitis. First one is microscopic polyangiitis. It is a necrotizing vasculitis of capillaries. That is why it is called microscopic, because it is going to affect mainly the capillaries. Fine? Yes. And it is also called as hypersensitive vasculitis or leukocytoclastic vasculitis. They will give you an option. Leukocytoclastic vasculitis is nothing else but microscopic polyangiitis. It is a hypersensitive vasculitis. Fine? Yes. Fine. Okay. And skin, mucous membrane of lungs, brain, okay, kidney, muscle, all are involved. Okay. And there may be a feature like history of glomerulonephritis. Okay, yes. And pathogenesis, remember, most of these cases are associated with MPO ANCA. I have already told in the introduction class, most of these are associated with MPO ANCA. MPO ANCA is C ANCA or P ANCA. Fine. See, C, P, all those are absolute. Okay, MPO ANCA, that's all. Fine. Okay. So what is the microscopy? Again, you will have segmental fibrinoid necrosis of the tunica media. It is almost like our pan. Okay, so because initially we have thought that there is a fibrinoid immune complex deposition, but in recent days only we have found that it is not because of immune complex deposition, but it is because of the antibodies which are directed against the myeloperoxidase. That is what we call it as MPO ANCA. Fine. Yes. And why it is called as leukocytoclastic vasculitis? Because there will be neutrophilic, predominantly there will be neutrophilic infiltration into the vessel wall. That is why it is called as leukocytoclastic vasculitis. So it is a pauci immune injury. I have told in my first session itself what are these are actually the medium sized vessel vasculitis that we are going to discuss are nothing else but a pauci immune injury, because there is no proper immune complex deposition. Fine. That is why it is called as pauci immune injury. Fine. Why it is called leukocytoclastic vasculitis? Because of the predominant leukocyte, that is a neutrophil infiltration into the blood vessel wall. Mainly it is going to affect the capillaries, post-capillary venules, small arterioles. Fine. So clinical features, there will be hematuria, hemoptysis, okay, hemoptysis, hematuria, proteinuria, palpably cutaneous purpura. You won't get this microscopic polyangiitis as a case scenario in this question because it is overlapping. It has a lot of features which overlaps with polyarthritis nodosa, which overlaps with our next condition that we are going to discuss, that is vaginous granulomatosis. So usually it won't be asked in a case scenario question. Just two important points. Just remember leukocytoclastic vasculitis, hypersensitivity vasculitis, and MPO ANCA. See? Okay, this is a leukocytoclastic vasculitis. You can see the neutrophilic infiltrates. Fine. Yes. Okay. And see neutrophilic infiltrates. You can see here. Okay. Fine. This is microscopic polyangiitis. What is the other condition? Granulomatosis with polyangiitis. It's a granulomatous lesion. Earlier, it was called as vaginous granulomatosis, but now this terminology has been obsolete. We are not using that. Now we are using only the terminology granulomatosis with polyangiitis. It has a triad. You should remember the triad. Acute necrotizing granuloma of upper and lower respiratory tract, necrotizing or granulomatous vasculitis of the small to medium sized vessel, and focal necrotizing crescentic glomerulonephritis. In glomerulonephritis, we have different patterns of glomerulonephritis: diffuse proliferative, mesangial-proliferative, membrano-proliferative, focal segmented glomerulonephritis. So all these terminologies we use in case of glomerulonephritis that we will see in the pathology of kidney. But as of now, just remember the triad, okay? Because they may give in any PG entrance exam, they may give you involvement of lungs. See, this is nothing else but the gross photo of some central cavitating lesions. Okay, you can see some central cavitating lesions of the lungs. I told you it's a triad. It mainly goes to involve the upper lower respiratory tract, vessels, as well as finally kidney. Okay, remember three things: lungs, vessels, kidney. Okay, this is the triad. Then coming into, yes, the pathogenesis, remember it is PR3 ANGA. PR3 ANGA, there in first microscopic polyangiitis we told it is, yes, MPO ANGA, here it is PR3 ANGA. Okay, this is the important culprit. Then coming into, yes, I told you there will be granulomas with geographic patterns of central necrosis and accompanying vasculitis. So remember, there will be granulomatous lesion in three areas. One is in the vessel, number two in the lungs, and number three in the kidney. Fine, these are the important points you have to remember. See, focal segmental necrotizing glomerulonephritis or crescentic type of glomerulonephritis, you can see. This is also usually associated with mycobacterial as well as fungal infections. Fine, multiple granulomatous lesions you can see, which these are geographic lesions. There will be central necrosis, cavitation, all those stuffs you can see. Fine, yes. Again, what is the case scenario they may get? Okay, in, yes. So as far as granulomatosis, vaginous granulomatosis, you won't get that much case scenario based questions, because microscopic polyangiitis and granulomatous, with the granulomatosis with polyangiitis, that is GPA, both of these conditions are overlapping. Okay, fine. Just they differ only in case of ANCA, that is MPO ANCA, and the granulomatosis with polyangiitis is what we call it as PRT ANCA. Okay, that is the difference. Okay. Then coming into the next most important thing, Churg-Strauss syndrome. Yes, here I am going to give you a case scenario. Churg-Strauss syndrome, I am going to give you a case scenario. A 21-year-old boy who is a known case of asthma presents with wheezing rhinitis. Lab result shows peripheral eosinophilia, anti-MPO antibodies. Anti-MPO antibodies. Fine? Yes. What's your probable diagnosis? Whenever you hear the word asthma, eosinophils, that is why Churg-Strauss syndrome is called as allergic granulomatosis and angiitis. It is associated with asthma, allergic rhinitis, peripheral eosinophilia, okay, and there will be extensive eosinophilic infiltrations of vessels and tissues. Okay, there will be cutaneous involvement with palpable purpura, GA bleeding, focal segmental glomerular necrosis. Fine. Yes, it may also lead to cardiomyopathy because of this what eosinophilic infiltrates into the cardiac tissues, myocardium. Fine. And I told you the MPO ANGAs are present. Okay, but it's not like the see actually in microscopic polyangiitis and Churg-Strauss syndrome. Here, this anti-MPO antibody levels are extremely high. This is only minor levels, okay, in minor levels, like less than 10% of cases, only anti-MPO antibodies, that is what we call as MPO ANCA. MPO ANCA has been found out. Fine. Just remember this point. Okay. So remember, just for your case scenario based question, you should remember this. Then coming into thromboangiitis obliterans, also called as Buerger's disease. Yes, this is again another case scenario. I am going to give a 32-year-old male smoker. That is a very, very important terminology, smoker, because there is a strong relationship with the cigarette usage and the occurrence of Buerger's disease or TAO. It is like a peripheral vascular disease. Fine. Yes. So, and the patient has complaints of some intermittent claudication. That is what the patient will feel difficult, some claudicating pain during walking and gangrene of the lower extremities. On examination, it has been found that there is loss of peripheral pulses and there has been tenderness along the nerve. Remember, in TAO, even though it is a vascular, it is going to mainly affect the arteries, but there will be vein involvement, there will be nerve involvement. So, artery, vein and nerve, all these three are simultaneously involved in case of TAO. Fine. What will be a probable diagnosis? Answer should be Buerger's disease or thromboangiitis obliterans. It is a segmental thrombo. Why it is called thrombo? Because it is a thrombotic disorder. Why it is angiitis? Inflammation of the blood vessel. Obliterans because it is finally going to occlude the blood vessel, leading to diminution and complete absence of pulsation. This is mainly going to affect the peripheral vessels, that is tibial artery, radial artery, ulnar artery, popliteal artery, superficial. Okay, but is like that is a peroneal artery, posterior tibial artery. All the peripheral arteries will be affected. Fine. Yes. So then coming into here, this is the Buerger's disease. You can see here finally a big thrombus has occluded, okay, and you can see infiltration with the leukocytes infiltration. Fine. Okay, coming into morphology, nothing much. There is luminal thrombosis, granulomatous inflammation. Okay, yes, okay, all these things just remember. usually associated with Raynaud's phenomenon. You know what is Raynaud's phenomenon? That is, during cold, when exposed to cold, there will be vasoconstriction of the small arteries of the digits. Fine, that is Raynaud's phenomenon. There will be vascular insufficiency in Buerger's disease. Finally, there will be gangrene, and finally, the treatment of choice will be only amputation. Fine, only amputation. Fine. Okay, so these are some of the important vasculitis. Of course, there is nothing to discuss in depth, okay, in about each of these condition. What you have to keep in mind is some of the most important, like distinct points, okay. Some in each of these condition, I have told some 3 to 4 distinct features that helps to differentiate from the rest of the condition, okay. Even in short notes also, of course, there is no material other than Robbins that gives this much information, or else if you want, you have to go to books like Harrison, but that's not needed for a student who is going to appear for a path exam. So just remember, in order to find the correct diagnosis from the case scenario, just remember what are the clinical features, what are the morphological features, the age group, the typical way of presentation. Each of this case has a typical way of presentation. I have already explained the case scenarios before I start discussing each of these conditions. So I hope that this session has been useful. Vasculitis is extremely important. Of course, even though each of this condition seems to be very small, but this is in other books like Ramdas Naik or whatever it may be, they have given like pages and pages. There is no need for that. If you read, just remember these points. If you can keep these things in your cortex, this is more than enough. Just go through the case scenarios. Just please go through the clinical features. Please don't skip the clinical features, because it is those clinical features that helps you to find the correct diagnosis. And yes, again, please keep that flow chart, the medium, large, small vessel vasculitis and the basic mechanism. In the first part of this vasculitis, I have in depth I have explained out. Please keep that flow chart and rest everything, the basic mechanism. When they ask about pathogens, you can write whether it's type 3, type 2, type 4 granulomatous, then you can write. So that is how you have to integrate the general pathology with systemic pathology. So with this, I'm coming to the end of this. So with this session, we have finished almost all aspects of blood vessel pathology. Fine, thank you.